Welcome, everyone. Thank you so much for joining us today. My name is Amy Sam. I am the Health Education Project Specialist with the Maxwell and Eleanor Blum Patient Family Learning Center at Mass General Hospital. Before we get started, just want to go over a few items with you all. Please note that today's session is being recorded for educational purposes. If you're interested in viewing the recording, you may visit the Blum Center website at massgeneral.org/Blum-Center. Please note that everyone is in listen-only mode. Everyone has been muted so that we can hear our guest speakers today. If you have any questions for our guest speakers, you may use the chat feature, which is located at the bottom of your screen. We'll have time for them in the end. Only Blum Center staff and guest speakers will see your questions. Please do not share any personal medical information or questions in the chat box. If you have a personal medical question, please ask your doctor. So next, I would like to introduce you all to our guest speakers today. Joining us today, we have Dr. Suman Srinivasa. Dr. Srinivasa is a board-certified endocrinologist in the Mass General Metabolism Unit and assistant professor of medicine at Harvard Medical School. She is a clinical expert in managing metabolic disease and HIV. She is currently leading clinical trials to further understand heart disease and HIV and to investigate new strategies to reduce heart disease risk. Joining us, we also have Allie Walpert. Allie is a clinical research nurse practitioner, also in the Mass General Metabolism Unit. She works closely with those living with HIV. Allie is focused on education, participant recruitment, and safety monitoring for two key studies of heart disease in people living with HIV, called the Enchantment study and Miracle study. Lastly, joining us, we also have Grace Shen. Grace is a graduate of Duke University and works in the Mass General Metabolism Unit, sorry, can't even get that correct, as a clinical research coordinator for the Enchantment study. She is a frontline resource for participants throughout their participation in the study. So please join us today in welcoming them. They join us to give a talk on heart disease and HIV.
Great, thank you so much, Amy, for that really nice introduction. I'll go ahead and share my screen. All right, so we are most delighted to be here today. Thank you to the Blum Patient and Family Center for having us today. We hope through the course of this talk that we can really shed some light on heart disease and HIV. There will be some interactive portions during the talk in which we hope you'll actively participate. And otherwise, we're happy to take questions at the end of our talk as well. So the outline for today's talk will be as follows. We'll first review heart disease and HIV. Next, we'll go into detail about two major types of heart disease that are important in HIV, coronary artery disease and heart failure. And following this, we'll discuss some prevention strategies, novel approaches to treatment, and then end on introducing you to one of our current heart health studies. Let's familiarize ourselves with some terms and abbreviations which we'll use throughout the talk. PWH will refer to persons living with HIV, while PWOH will refer to persons living without HIV. HIV can progress to AIDS if not adequately treated. And ART will refer to antiretroviral therapies, which are used to treat HIV to increase immune function and reduce viral load, often come in the form of pills and combination therapies, but currently there are also injectable forms as well. And finally, CVD will refer to cardiovascular disease, which is a broad term for heart disease. To start with, let's understand the prevalence of HIV. These are data taken from the CDC. This map displays estimates of persons with HIV over the age of 13 in the US in 2019. And while new rates of infection are declining, it is estimated that there are approximately 1.2 million persons living with HIV. And so it is important that we focus on the clinical care of these patients. Let's begin to discuss heart disease and HIV. We'll start with an interactive question. True or false? Persons with HIV are at higher risk for heart disease compared to those without.
Sorry, give me one moment, okay?
You should have a poll that has shown up on your screen, and feel free to answer.
Okay, we'll give it another second for anyone who hasn't answered to enter a response. All right, closing the poll.
Okay, great. And we can see the results here. Everyone answered true. And so that is the answer. And we'll go into this further. In 2012, editors at the New York Times published a high-profile article proclaiming that heart trouble comes early and often in HIV. So much attention is really focused on trying to understand why persons with HIV are at increased risk. It's important that we try to understand the underlying causes, as this will really help us develop prevention and treatment strategies to reduce the risk of heart disease and HIV. The use of antiretroviral therapies have really transformed HIV to a chronic medical condition. What we mean by this is that antiretroviral therapies have improved survival among those persons living with HIV, and persons with HIV are living longer with treatment. And while life expectancy in the HIV population is still lower than the general population, it has been increasing over time, and the prevalence of opportunistic infections is down thanks to these medications, which is great. But now we see that persons with HIV are more susceptible to other chronic diseases and non-AIDS related disease, for example, diabetes, liver disease, cancers, and cardiovascular disease, or CVD, which will be the focus of this talk. So these are data collected from the Medicaid Medicare database over a 10-year period. And indeed, we see that there is an increasing trend of metabolic disease in HIV, an almost doubling of cardiovascular events, and a clear rise in comorbidities such as kidney disease, diabetes, obesity. And keeping in mind that these data are from 2013, so the numbers continue to evolve further, most likely. In fact, it is thought that over half of persons with HIV will die of non-AIDS related diseases these days, including heart disease, malignancies, and liver disease. So in this regard, the cause of death in HIV is shifted away from opportunistic infections and immune dysregulation, really to metabolic complications, even among well-treated persons with HIV. And this really highlights the need to address these issues and make this part of our routine clinical care for our patients. So what are the possible risk factors for cardiovascular disease in HIV? We can try to characterize this into 3 buckets. The first being traditional risk factors. So these factors would be ones that you would typically associate with heart disease in the general population, including factors such as age, high blood pressure, otherwise known as hypertension, or bad cholesterol, which we refer to as dyslipidemia, diabetes, family history, obesity, smoking, diet, and exercise. So risk factors are often discussed as modifiable, meaning things that you can change, such as an unhealthy diet or reduced exercise, and non-modifiable factors, such as things that you can't change, like age and family history. There are also many factors unique to HIV, such as effects from ART, as well as low CD4 counts or immune dysregulation, uncontrolled viremia, lipodystrophy as well. Some of you may be familiar with this term. It is a type of fat redistribution in which the individual may gain more visceral fat in the belly and fat surrounding the organs. And this is a bad type of fat that is more inflamed. Other factors that are HIV specific include hepatitis C co-infection, and insulin resistance, which insulin resistance is a precursor to diabetes, in which the body doesn't use insulin as well to control sugars. And finally, we can also think about newer non-traditional risk factors, such as inflammation and chronic immune activation. And this is important because inflammation may be the precursor or start to developing heart disease and other metabolic diseases. And another point that we'll continue to emphasize throughout the talk is that even those well treated on antiretroviral therapies will continue to have chronic inflammation. Indeed, when we look closely at these traditional risk factors for heart disease, we can see that there is a higher prevalence of many risk factors, such as shown here: smoking, bad cholesterol, high blood pressure, and diabetes, where the light blue bars represent those with HIV and the darker blue bars represent those without HIV. These data were taken right here using the Mass General Brigham Clinical Database. And so we could simply conclude that this is why persons with HIV have a higher risk of heart disease from these factors, but it is much more complex than that, as we'll see in the following slides. Shown here again are data taken from the Mass General Brigham database, and we see that there is a rate of heart attack, or MI, or coronary heart disease, that is 1.5 to 2-fold greater amongst persons with HIV compared to those without HIV, shown in the bar graphs on the left. In the middle graph, you'll see across all age groups, the rate of heart attack was consistently higher for persons in HIV compared to those in the non-HIV group. And the curve starts to separate with age as well, suggesting that older age increases risk further. And in further modeling, it was also shown that there is the increased risk is not solely accounted for by typical risk factors associated with heart disease, such as age, gender, race, blood pressure, diabetes, cholesterol, but in fact, diabetes, hypertension, and dyslipidemia, though increased, only accounted for about 1/4 of this risk of heart disease. So it's not just the traditional risk factors at play here. It may be those unique HIV specific and non-traditional factors that are contributing. Okay, we have another question to pose. True or false? Continuous use of ART is beneficial to help reduce the risk of heart disease.
Okay, we'll give it a few more seconds for folks to enter a response. All right, closing the poll.
Okay, great. And we can see again that everyone answered true. And indeed, the answer is true. Continuous ART is beneficial to help reduce the risk of heart disease, and we'll review the evidence of this. So ART were previously implicated as one of the main causes of heart disease in HIV. It was shown in one study here that increasing years of ART use was linked to an increased risk of heart disease. We know that certain classes of ART have adverse metabolic side effects related to lipodystrophy and mitochondrial dysfunction, and may further result in bad cholesterol and insulin resistance. And to that end, these could add to the risk of cardiovascular disease. Now, this is a very busy slide, but is meant to show that ART under different classes have been looked at to understand the effects on metabolic disease and cardiovascular disease risk factors. Over time, it's really been hard to tease apart the effects of each singular ART medication since they are typically used in combination. Now, the protease inhibitor class is generally thought to increase cholesterol and triglycerides and also contribute to insulin resistance. And some of you may be familiar with ritonavir, which was used at higher doses in the past and can contribute to insulin resistance. These days, ritonavir is used only at boosting doses and probably has less of an effect. Various NNRTIs were thought to have an effect on cholesterol and mitochondrial function. And the first line of ART regimens these days are NRTIs as well as integrase inhibitors. NRTIs have a neutral effect on cholesterol. And one NRTI, though, abacavir, has been directly linked potentially to heart disease and is not often used these days as patients have generally been switched from this medication. And the integrase inhibitors are generally favorable medications with regards to cholesterol. We do know that this class of medications may be associated with weight gain, though, and how this may secondarily, if at all, contribute to heart disease is rather unknown right now. What we do know is that over time, the newer ART developed tend to have less of these metabolic side effects than most of the older ART. And despite some of the metabolic effects of ART, what we do know is that, as you guys answered, there is an overall benefit to ART in reducing heart disease risk. The SMART trial, which was a landmark trial, really helped change our thinking and highlighted the beneficial role of ART. In this study, patients were randomized to continuous ART versus intermittent ART, meaning that ART was started when a CD4 count was less than 250 or stopped when a CD4 count was less than 350, the so-called start-stop method. And it was thought that maybe the start-stop method would be better due to the metabolic side effects of ART. However, the opposite was seen in that there was an overwhelming benefit to continuing ART, such that it would have been unethical to continue the start-stop method amongst patients. And shown here are data from the SMART study. The lower curves indicate lower events, which is good and protective. And those that were on continuous ART not only had lower events related to death or AIDS-related disease, as shown here on the left, but they also had lower events related to heart disease, as well as liver and kidney disease, shown here on the right. It was thought that this might be possible effects of ART on reducing heart disease through suppressing viral load and improving immune function or decreasing inflammation. So the SMART study results had a great impact and changed the ART guidelines around 2012. The US Department of Health and Human Services strongly recommended initiation of ART at a CD4 count less than 350. And they are cited as saying there's growing evidence that untreated HIV infection or uncontrolled viremia is associated with the development of non-AIDS defining diseases, including cardiovascular disease, kidney disease, liver disease, neurologic complications, and malignancies. Furthermore, newer ART regimens are more effective, more convenient, and better tolerated than regimens used in the past. And similarly, the World Health Organization changed their recommendations as well. Next, the START trial taught us even more about ART. In this study, patients with HIV were randomized either to early ART, regardless of the CD4 count, or delayed RT, such that medications were started when the CD4 count was below 350. Again, the study was stopped early as there was increased risk to those that were delayed in starting their ART, and thus there was an overall benefit to early start. Again, shown below, the lower curve indicates lower events, and those in the early initiation group had an overall combined reduction in AIDS and non-AIDS related events. And the non-AIDS events included heart disease. Since the study was stopped early, they couldn't assess heart disease alone as in the prior study, but it was assumed overall, as this was in the group of non-AIDS related events, that there was shown to be a benefit. And due to the results of the START study, the ART recommendations were again revised. The US Department of Health and Human Services now states that ART is recommended in all persons with HIV infection to reduce morbidity and mortality and to prevent transmission to others. Durable viral suppression improves immune function, the overall quality of life, lowers the risk of both AIDS-defining and non-AIDS defining complications, and allows persons with HIV infection to live a lifespan approaching that of persons without HIV infection. And the WHO also made similar updates. And so really immediate treatment with ART is now the standard of care in HIV. So we previously discussed that traditional risk factors may account for all of the heart disease risks in HIV, such as age, tobacco, and family history. And here indeed, this study shows that other factors such as HIV-specific factors, including older ART regimens, lipodystrophy changes in body composition, and a lower CD4 count may also contribute to heart disease risk. And in addition, increased markers of inflammation immune activation may also impact the risk of non-AIDS related disease, such as heart disease. So it is overall important to think about traditional HIV specific as non-traditional risk factors when thinking about heart disease and HIV. And now I'll go ahead and turn it over to Allie.
Thank you. So I will be talking more about the specifics related to the different types of heart disease that we'll be discussing today. So this is just to give you a visual representation of the structures of the heart. On the left, you have, it kind of just shows how the different chambers of the heart. So oxygen poor blood from the body goes into the right atrium, then into the right ventricle, then to the lungs to become oxygenated, then the left atrium, left ventricle, and then into the body. And then on the right, this shows the arteries that feed into your heart. These are the coronary arteries, right coronary artery, left anterior descending, left circumflex, left main coronary artery. And there's a whole spectrum of cardiovascular disease. There are many disorders involving the heart. This could include disorders of the conduction system, the heart muscle itself, and the valves within the heart. We will be concentrating on coronary artery disease. This is the most common form of heart disease, as well as heart failure. And then on the right, this again highlights the different risk factors that we've already touched upon: smoking, diabetes, high cholesterol, high blood pressure, obesity, physical inactivity, and then HIV is also an important risk factor, as we've discussed. So we will focus on, as I mentioned, two types of heart disease in this talk, the two very common forms, the coronary artery disease, which is an atherosclerosis, which can be small or large vessel disease, and this has to do with plaque buildup, and then heart failure, which is when the filling or pumping function is altered. So to go into more detail, atherosclerosis, which is a term you may have heard before, refers to the plaque buildup in the arteries. So you start with plaque buildup, which then leads to blood vessel wall thickening, which leads to narrowing of the artery, which then leads to reduced blood flow and then less oxygen reaching the body. And coronary artery disease is specifically when there's plaque in the arteries in or leading to the heart, because there can be plaque in other arteries in the body. And a heart attack can occur if the blood flow to the heart is severely reduced or stopped. And the same happens in strokes when the blood flow to the brain is interrupted. So plaque can also cause such narrowing of the arteries that blood clots can form. And even a piece of plaque can break off and get stuck. And this also leads to interrupted blood flow. So if you look at the picture, this shows a normal artery up top, and the blood can freely flow through there and get to the parts of the body that it needs to go. But the artery below is narrowed because of plaque, so it's harder for the blood to flow freely. So more specifically, coronary artery and artery disease and HIV. HIV is associated with other health conditions, including abnormal cholesterol levels, insulin resistance, and body composition changes, which can also increase the risk for heart disease. The risk of coronary artery disease is doubled among people with HIV compared to those without HIV, even when you control for the common risk factors that everyone has. Chronic inflammation and immune activation are increased even in well-controlled and well-treated HIV infection. And there are higher levels of inflammatory markers in the blood, which are associated with coronary artery disease and other heart disease in those with HIV. So another true or false question, persons with HIV have evidence of increased heart disease even before symptoms occur.
We'll give folks a few more seconds. All right. Ending the poll.
All right, so yep, 5 out of 5 people said that the answer is true, and it is true. Persons with HIV have evidence of increased heart disease even before symptoms occur. We refer to this as subclinical disease, and I'll explain in further slides. So there is increased coronary plaque among well-treated persons with HIV with no known history of heart disease. We can use CT scans or a type of CT scan, coronary CTA, to image coronary plaque. And as you can see in this graph, 59% of persons with HIV have presence of plaque compared to about 34% of persons without HIV. And if you also look at the images below, this is looking at the plaque over 12 months in persons with HIV, and there's no treatment in these 12 months. And then you can see that after 12 months without intervention, 80% of persons with HIV did have a progression of plaque, which is shown in the circled area. We can also use aortic FDG PET scans. So that's just another imaging technique to look at inflammation in the large vessels of the heart. These images are from a PET scan of the aorta. We can see that there is increased aortic inflammation even among well-treated persons with HIV with no known history of heart disease compared to those without HIV. And so that's, you can see in the images, these are just different views of the aorta, that those, someone without HIV is not, their aorta is not as lit up as a person with HIV. So that's just showing that there is more inflammation in the aorta. And this is important to think about preventing heart disease even before someone has symptoms, because their increased aortic inflammation is associated with cardiovascular events. So symptoms. So like I mentioned, many people have no symptoms at all. The symptoms that occur with exercise, that's often called angina, and that can be pain, pressure, discomfort in the chest, pain, tingling, discomfort in other parts of the body, including arms, neck, jaw, stomach, also shortness of breath. And then this coronary artery disease can lead to a heart attack, and people may experience the same symptoms as above, and can also include nausea, vomiting, burping, heartburn, sweating, cold, clammy skin, racing or uneven heartbeat, dizziness or lightheadedness. And it can vary from person to person, but obviously if you're worried you're experiencing any kind of cardiac event or heart attack, call 911. So next we'll move on to heart failure. So heart failure is when the heart does not fill with blood or pump adequately. And it has been called many things over the years, including congestive heart failure, right or left-sided heart failure, diastolic or systolic heart failure. And now we tend to classify it based on the pumping function and if it is preserved or reduced. And ejection fraction is how much blood is pumped out of the heart with each heartbeat. And so there's heart failure with reduced ejection fraction, which means that the pumping function is impaired. And then there's heart failure with preserved ejection fraction, which is the pumping function is okay, but the heart's not filling adequately with blood. So specifically, heart failure and HIV, as was mentioned previously in a previous slide, people with HIV have a 1.5 to 2-fold higher risk for heart failure compared to those without HIV. But the exact reasoning for this is not completely clear and not completely defined, and we're continuing to research it. But we do know that a detectable HIV viral load and a lower CD4 count are linked to higher heart failure risks for people with HIV, but even those with good viral conditions for heart failure than persons without HIV, because there is still chronic inflammation and immune activation. And so this just shows the evolving epidemiology of heart failure and cardiac dysfunction in those with HIV. Some of these studies were mentioned in previous slides, but the timeline starts from when HIV was first discovered in 1983, and AIDS cardiomyopathy was more prevalent due to inadequate treatment of HIV. And this was thought of as heart failure with reduced ejection fraction, More recently, with the use of ART, that's more effective at treating HIV. And the newer recommendations for immediate start of ART, as we discussed with the SMART and START trials, the type of heart failure associated with HIV has now shifted to heart failure with preserved ejection fraction. But there's still more to be done in terms of investigating heart failure and heart disease in persons with HIV. So this is just a visual representation of some risk factors specific to those with HIV, plus there's the traditional risk factors. And you can see that there's unique as well as overlapping risk factors specific to each subtype of heart failure. So with the reduced ejection fraction and preserved ejection fraction, we typically think of coronary artery disease as a mediator of heart failure with reduced ejection fraction, metabolic disease such as obesity, hypertension, diabetes, renal disease, and other risk factors. Aging and inflammation are thought to be risk factors for heart failure with preserved ejection fraction, all of which are relevant to our HIV population. Symptoms. So again, this can also vary from person to person, and at first there might not be any symptoms, but as heart failure progresses, the symptoms become more apparent and severe. Currently, our group is studying subclinical heart failure, meaning there's evidence on cardiac imaging that heart failure may develop in the future, but there's no associated symptoms. Symptoms may vary and can include shortness of breath, difficulty breathing, may require several pillows at night to prop the head up due to difficulty breathing while laying flat, tiredness or weakness, lightheadedness, dizziness, leg, feet, ankle swelling, a rapid heart rate, even at rest, and then with severe heart failure, unintentional weight loss. So heart disease can be diagnosed in a variety of ways. So if someone has symptoms concerning for a heart problem, a provider would do a health history and physical exam, and then possibly any combination of this testing, including an electrocardiogram, which looks at electrical activity in the heart, blood work, a chest x-ray, echocardiogram, which is an ultrasound to assess the heart structure and function and blood flow through the heart. Exercise testing, this is also known as stress testing, and this can be done, either doing with exercise or with a medication. More invasive testing, such as cardiac catheterization, and then there's other imaging, as mentioned, CT scans to evaluate for plaque, and MRI to evaluate heart structure, function, and inflammation. So the traditional treatments that are available for heart disease are numerous and vary from person to person, and depends on symptoms and severity, and can include medication for coronary artery disease, can include medications to manage symptoms and prevent cardiovascular events from happening, can be done to improve blood flow to the heart, and these include more invasive procedures like a CABG or PCI. And for heart failure, there's often an underlying cause, such as a blood flow problem, heart valve issue, heart muscle issue, uncontrolled high blood pressure, diabetes, a conduction issue. So treatment of that is important, as well as some medications to manage symptoms and improve heart function. There's cardiac rehab, also more invasive treatments, as well as heart transplant. And then importantly, reducing risk factors is important, and the next few slides will outline that. So heart disease prevention. So these are some measures that can be taken to prevent heart disease. You can make lifestyle modifications specifically to diet and exercise, management of the traditional risk factors, continuing to take your prescribed medications, including medications for HIV, high blood pressure, high cholesterol, diabetes, and continuing to take antiretrovirals, because discontinuing antiretrovirals and uncontrolled HIV are associated with a higher risk of heart disease. So another question, a final question, true or false, the average American consumes about 1,000 milligrams more than the recommended amount of sodium per day?
Give it a few more seconds for folks to enter the poll. Closing the poll.
All right, so there's a bit of a split with this one, but the answer is true. The recommended daily intake of sodium for most people is 2,300 milligrams per day, and an even lower intake may be recommended if you have known heart disease, but the average American actually consumes about 3,400 milligrams of sodium per day. So diet is, as mentioned, very important in reducing risk factors for heart disease. As mentioned, so many foods have so much more sodium than you think, and preparing your own foods, while more work and more time consuming, it can be healthier than eating pre-made meals or getting food from restaurants. But if you do, buy pre-made meals, just make sure to look at the nutrition facts, and I can tell you how much sodium is in there. It's important to avoid processed foods whenever possible. I know it's often not possible, and avoid adding salt when you cook or at the table, especially if it's a pre-made meal. There's often plenty of salt in there already. Eating fresh fruits and vegetables is important, but canned and frozen can be okay. Again, just check the nutrition label for sodium and sugar content, since that can vary even from brand to brand. And fiber can prevent heart disease and strokes, and can also help control type 2 diabetes. Protein is an important part of the diet. There's many protein sources, including poultry, seafood, eggs, vegetarian sources of protein. Even some whole grains have some protein, and limiting red meat is important. It can be a good source of protein and other nutrients, but can also have a lot of fat. So just trying to choose a leaner cut of meat. And then avoiding trans fats and excess sugar. Again, the nutrition labels will help, and as well as the ingredient lists, and partially hydrogenated oils are trans fat if you're looking at the ingredient list. And everything in moderation. Overly restrictive diets are harmful too, and then can cause overindulgence. So it's okay to indulge every now and then, and variety is key, mixing up your fruits, vegetables, grains, proteins. And this is just a nice visual representation of what you should be aiming for your plates to look like, with a large proportion being vegetables and fruits, healthy proteins, whole grains. And it's important to just vary your macronutrients with the focus on the fruits and the vegetables. And yeah, this is just a model of how to assemble your plate. And then nutrition labels, they can be confusing, but most foods, especially if it's like a packaged food, should have this on there. And it tells you like the actual amount in there, but then also the percentage of your daily value, which I find more useful and helpful in trying to plan how much of it that I may eat, or if I'm going to buy that item or not. And so, yeah, these are a great way to tell how much of each fat, sodium, and vitamins that you're getting. Exercise is also very important. So try to exercise for 30 minutes per day, at least 5 days per week, and vary your workouts, including a mix of cardio, resistance training, stretching, and you don't need to necessarily go to the gym for this. There's plenty you can do without equipment, such as brisk walking, push-ups, squats. And you just want to be sure that you warm up before you exercise and cool down after to help prevent injury. Lifestyle modification, so smoking cessation. It's never too late to quit smoking. Atherosclerosis and heart attacks. So, cutting down or stopping completely will definitely be beneficial. Limiting alcohol consumption. It's not really clear how much is a healthy amount of alcohol, but just try to reduce consumption in general. And certain substances, specifically cocaine, is also associated with heart disease and coronary plaque. But it's important to contact your provider to discuss a safe way to make these lifestyle modifications. stress reduction. So it's easier said than done, but managing stress levels is definitely important for heart health. You want to reduce triggers if possible, practice self-care, set realistic goals and expectations. You can do deep breathing, meditation, mindfulness exercises, and these don't even need to take very much time. And there's plenty of resources, free resources on the internet, mindfulness apps, meditation videos, etc. And so this is something that you could do with your provider. It's a clinical risk calculator for atherosclerotic heart disease and predicting the probability of having a heart-related event over the next 10 years. And this is if you have no known history of heart disease. But the problem with this calculator is that it may underpredict risk of cardiovascular disease in those with HIV, because they don't specifically account for or ask about HIV status or specific risk factors. But they did address it just by saying that it could be underpredicted. And they did add that section. So this is something that you could do with a provider. So prevention strategies, modifying traditional cardiovascular risk factors in HIV. So there's blood pressure control. I mean, all these things, you want to do with your provider because they have to do with medication and controlling medications and monitoring parameters, but there's blood pressure control, so reducing sodium intake, as I mentioned, and having, if you are on a blood pressure medication or considering a heart blood pressure medication, again, with your provider, for a blood pressure goal of less than 130/80, then blood sugar control, so reducing carbohydrate intake, considering anti-diabetic medication, and considering insulin sensitizing medications like metformin. There's cholesterol modification, so reducing fat intake and considering a statin medication, and then weight reduction. So this can vary from person to person, but the healthy BMI is between 18.5 to 24.9. So novel approaches to treatment is the next section. So future treatment strategies should address HIV-specific and non-traditional cardiovascular risk factors. That includes immune modulation and or anti-inflammatory agents. So this is just a list of medications that have been studied. Some of them have shown not to have benefit. Other ones like statins, there is a large international trial ongoing, and it does show that statins have been shown to have a possible benefit, but further studies are ongoing on that, as well as bringing us into the next section. There's the renin-angiotensin-aldosterone system blockade, and we'll talk about this one more in the next slide. So the RAS system, aldosterone is a hormone that everybody makes, and it is responsible for blood pressure regulation and sodium balance. And it is elevated in persons with HIV compared to people without HIV. And excess aldosterone hormone is associated with visceral fat, insulin resistance, and inflammation in HIV, and has been linked to heart disease as well in the general population. So we are currently investigating whether this process could be aldosterone mediated, so aldosterone leading to inflammation, leading to plaque buildup, and leading to heart failure. So our studies have been looking at this. Which brings us to the next section, which Grace will tell us about our ongoing research.
Thank you, Allie. Yeah, as Allie just so clearly mentioned, there is a potential, or we're really interested in the relationship between the RAS system, aldosterone, and this increased risk of heart failure or heart disease in people living with HIV. Our team is currently conducting the Enchantment HIV study, which you can see on the screen stands for something much longer. But basically in our study, we're trying to understand if aldosterone is related to these changes we see in the structure and function of the heart in people with HIV who have no prior history of heart disease. So again, we're looking for people with no prior history, but may show signs of subclinical heart failure. In our study, we also look at the effects of lifestyle modification, so changes in diet and physical activity, and the effect of an FDA-approved medication called sacubitril valsartan to see if they also have an effect on the risk of heart disease and if they might change and improve heart structure and function and reduce inflammation in the heart in people living with HIV after 6 months. So currently we are recruiting for participants between the ages of 40 and 70 years old. We're also looking for an increased waist circumference or an increased waist to hip ratio. And also almost all of our participants who screen for our study will also get a cardiac echo or a cardiac ultrasound where we will see evaluate your ejection fraction and look at your heart basically. So we are looking for participants with an ejection fraction of greater than 50% or a preserved ejection fraction, as Allie mentioned earlier. And we are also looking for one or more criteria for a changed structure or function on the heart ultrasound that might indicate the progression of heart failure with preserved ejection fraction. We are also looking for participants who have been on ART use for at least 12 months and have a controlled viral load. Our study includes a lot of components, so this is a long list, but this is not what you experience in just one visit, but rather what you experience across the study. So we do ask you for your medical history, and we do physical examinations, blood draws. We also do body composition measurements. Like I just mentioned, almost all participants who screen for our study will get a heart ultrasound. And again, ultrasound is the same form of imaging that pregnant mothers get to inspect the baby. And there's also a cardiac MRI with a stress portion. Neither of these imaging involve radiation. We also give you a low sodium diet for 6 days. Aldosterone and sodium, like Allie mentioned, have a very tight relationship. So this is a way for us to study the aldosterone levels. And all participants who qualify for the whole study will take either sacubitril valsartan or placebo for 6 months. You'll also receive nutrition and lifestyle counseling for 6 months with the dietitians on the research floor at Mass General. There are 11 visits in total, so 8 outpatient visits and 3 overnight visits. Depending on the visit, you'll either be at Mass General or at Brigham and Women's. And this study we don't ask anything of you other than your time. We do compensate you up to $595 if you qualify for the whole study. And we can also help you with travel, whether you're driving or taking the T. And with that, that's everything we have for our presentation today. Thank you so much for listening. If you're interested in learning more about our team or our study, feel free to check us out on our website at the Metabolism Unit and also our social media. Feel free to send us an email if you have any more questions. And this QR code does also lead to our study website if you're interested in learning more about our study. There are also a few questions in the chat, so we'll definitely take those questions. Feel free to send more questions in the chat.
Thank you so much, Grace. As Grace had mentioned, we are at the end of the session. So if you have any questions for our guest speakers, feel free to enter them in the chat. So we have a question about having a conversation with someone. How early do you recommend starting the conversation with a loved one about heart disease and HIV? For example, what age group do you generally start providing information about this subject?
So I can touch upon that, and I can leave Dr. Srinivasa to fill in any gaps. But so that is a tough question. I think, for anyone, heart disease and heart health should just, be in the back of your mind. For our studies specifically are looking at people ages 40 to 70, but it's not, tied specifically to that. I think it doesn't hurt to mention it at any age, but leaving it ultimately to the provider, either the primary care provider or infectious disease. More research coming out about heart disease in those living with HIV. I think this is more on people's providers' radars than maybe it had been in the past.
Thanks, Allie. Yeah, that was a great question. And I have to agree that in general, I think heart disease should be a focus for everyone, regardless of your health history for everyone. So it's never too early to have these talks. I think one important point that we were trying to make across all of this is to bring light to the fact that heart disease does occur at an increased rate in HIV. So even just having that knowledge is something that we wanted to share, and something that you can share with your loved one or have a talk about, and then take slow steps towards improving that heart health or doing what you can to prevent heart disease. And as we discussed, one of the most important things to do is, if not already done, is to speak with your provider about starting antiretroviral therapy, as we know that has benefits not only to heart disease, but many other chronic diseases, as well as, of course, complications related to HIV. And from that, then sort of other discussions can be made, and other strategies that we discussed, maybe in terms of diet and exercise, can be incorporated very easily for anyone. And hopefully, in the coming years, as we discussed, there are many treatment strategies being studied, and we're hopeful that we can bring something to our patients in the upcoming years to help reduce this risk as well.
Thank you. Allie, earlier in your slides, you had mentioned cardiac rehab. Can you talk a little bit more about that and what that entails?
Oh, yes. So that is one of the many treatments for heart failure. It's a way that people who are maybe having a lot of difficulty doing their daily activities due to heart failure, because they're very short of breath, or unable to walk as far, or just become fatigued. So this kind of helps get people back to maybe doing more activities independently if possible, and just help get their heart, pumping as more efficiently. It's not usually a treatment that's used alone. It's more in conjunction with other treatments for heart failure. But it's almost sort of like physical therapy in that sense.
Are there any programs available where a patient can work one-on-one with someone on healthy eating and exercising?
Yeah, so some of that is through providers, can make referrals to dietitians, and but yeah, I think it's hard to know specific programs. Often it's through like a provider referral, but there are, I know at MGH there are programs, and I think a lot of major hospitals, but I wish there were more. There should be more available to everyone. But yeah, I think there are dietitian programs, specifically I know in the HIV infectious disease program here.
Patients may also be able to, the government has a few websites also, and as Allie showed, there's myplate.gov and the healthy eating sort of strategy, which if you have access to the internet, you can feel free to go to some of those websites, and there will be a lot of useful information on small changes that you can make, or things that you may have not learned before. I think that, and then in addition, sort of, as we mentioned, learning to read nutrition labels can also be a very important strategy that you can do yourself, at the grocery market when you're looking for foods that may be a little healthier. And it is important to have this discussion with your provider as well, if this is something of interest to you, because oftentimes the appointment may be devoted to other things within your medical history, but this is in fact another really important piece of everyone's health, is to discuss diet and exercise. So I encourage everyone to really bring that up with your providers. There are also resources that they can direct you to, and referrals at Mass General. So hopefully all of these together can provide some help. And in addition, as we mentioned, one great thing about getting involved with our research study as well is that you will meet with a nutritionist here at Mass General who can help work on goals with you. We have a set curriculum, but can help personalize your goals and help come up with strategies that may be useful day to day for you in improving your diet.
And will this all be done on site or can this be done remotely?
So with regards to the nutrition counseling through our study, there are portions of the study that are in person, but the nutrition counseling, if in conjunction with the research study, could be done virtually actually. So we do have some accessibility for that.
Thank you. Are there any tips you have about how we can reduce the stigma about HIV?
That's a big, like, that's an ongoing thing. I hope that, I think over the years, the stigma has lessened. I know there is still some, and it depends on parts of the country or parts of the world that you're in. But I think doing things like this, talking about it, and just normalizing it as another health problem that anyone could have, can help to destigmatize HIV.
I agree. And if I can add something to that, I think, especially in the younger generation, I think promoting getting like HIV testing from like a younger age, I think will help the younger generation as we grow older also normalize and reduce the stigma about HIV.
Thank you. Before we end today's sessions about that time, do you have any final thoughts you'd like to share with the audience?
Well, we just want to thank you so much for letting us share our knowledge about HIV and heart disease, and thank you for attending. We hope this session was helpful.
Yeah, thank you again for having us. And most importantly, we hope that this brings to light something as a part of very important to your health history and something that you can discuss with your providers going forth.
All right. Well, thank you so much for a wonderful presentation. Thank you everyone for joining us today. As I had mentioned, this session is being recorded. So if you're interested in viewing the recording, it will be made available on the Blum Center website at massgeneral.org/Blum-Center. Thank you so much, everyone. Have a lovely rest of the day.